So now we've talked about that time, and if you do some invasive surgical procedures like an open or laparoscopic surgery, there is a high possibility that they would have problems subsequently in access to the kidney. So therefore, it is important that the children should always be treated as minimally invasively as possible. We'll see how it is possible. Now, urological evaluation along with the metabolic workup is extremely important to prevent recurrences. The various metabolic causes, and we are going to talk about various types of stones, and the various metabolic causes include hypercalciuria, which is probably the most important. These stones are calcium oxalate, calcium phosphate, and these are the commonest stone. The reason why they are formed, and we all know that the stone formation is really related to two factors. Number one is supersaturation, and the other theory is Rendell's plaque. So supersaturation is the more accepted cause for urolithiasis in children, and hypercalciuria, which is increased calcium excretion, hyperoxaluria, they are both factors. The other factor is the decreased concentration of various electrolytes which are responsible for prevention of stone disease. So which obviously includes citrate and magnesium. And all these factors need to be assessed because there is a strong possibility of having these factors. You can see two types of stone. A full stone, which is picture A, is the typical calcium oxalate monohydrate stone. And this is the cut surface. And you can see even by looking at it that the stone is really hard. And that's why calcium oxalate monohydrate stones are really the toughest stone to treat by any fragmentation device. This is calcium oxalate dihydrate stone and the cut surface. And these are the stones which are relatively softer and easier to treat. Now, hypercalciuria, which is a significant cause of recurrent calcium oxalate and calcium phosphate related stone, is excretion of greater than 4 milligrams per kilogram body weight of calcium in 24 hours. Now, majority of these are idiopathic or secondary hypercalciuria. Important factor is the sodium. And as we will see subsequently in adults as well, the high sodium chloride intake is responsible for idiopathic or secondary hypercalciuria. The other causes of hypercalciuria includes the calcium mobilization from various resources like bone. So hyperparathyroidism, hyperthyroidism, immobilization, acidosis, metastatic disease, relatively less common in children, but they can be the causes for increased calcium excretion. The increased absorption of calcium and subsequently increased calcium excretion seen in hypervitaminosis D. This is a fashionable thing these days to take vitamin D. And if your vitamin D levels are already normal and you absorb more calcium from the gut, and as a consequence, what happens that you will be excreting more calcium from your urinary tract, and as a consequence, you can develop. The diagnosis is difficult because as the pediatric surgeons and pediatricians will tell you that collection of 24 hours urine is difficult in children. It's difficult for particularly in young infants to collect 24 hours. So one of the easiest thing to do is on a spot urine sample, you do a calcium creatinine ratio. And if the calcium creatinine ratio is greater than 0.2, then there is a possibility that there is a hypercalciuria, and then these children should undergo definite metabolic 24 hours collection and treatment. And then obviously we know that for very young children, it is difficult. So the 4 hours, 6 hours, or multiple spot values and extrapolating on that. Now, once you have identified that there is hypercalciuria, then the treatment is obviously of the cause. But for idiopathic types, fluid intake increase, dietary modification with cut down on salt, use of thiazide, diuretics, and citrate. They're all useful to prevent calcium oxalate stone formation. So calcium oxalate is seen in predominantly about more than 50% of children, and so is in adults as well, that calcium oxalate. Calcium phosphate stone in about 15 to 30%, screw white stone, but obviously these data vary significantly depending upon what part of the world are you living. And even in Pakistan, in various cities or in smaller towns, the cause and the percentages will vary, but generally this is what is accepted. A lot of patients now have mixed stone, but the important thing is that what is the predominant form. So if it is uric acid and calcium oxalate, you see what is the predominant form, and if it is the calcium oxalate which is predominant, that's the primary cause, not the uric acid. Hyperoxaluria is again another significant thing, and it to the dietary intake, enteric hyperabsorption, which could be in small bowel syndromes, or as an inborn error of metabolism. So primary hyperoxaluria is an inborn error of metabolism. It is an atrophy in the liver, and that can result in CKD oxalosis. Oxalosis means oxalate of the parameters. Again, one of the easier things that to do is determine the oxalate creatinine ratio, and these are the various ranges of oxalate creatinine ratio, and based upon this you would decide whether the child require a more detailed metabolic evaluation. Hypocitraturia, which means citrate is one of the factor which prevents stone formation and crystallization, and this is done by binding to calcium and excreting calcium from the body. You can this direct binding effect is for both plate and calcium phosphate stones. That's why it's typically used for uric acid stones, but it can be active in other types of stones, including calcium oxalate stone. The deficiency of these things of citrate is a factor, and in various studies from Pakistan, we have seen that we are quite deficient in citrate. But interestingly, this citrate deficiency is not only in stone former, but is also seen in non-stone former. So we don't know what is the correct cutoff. Renal dysfunction, then potassium citrate should be, you should be very careful about use of potassium citrate. Sodium citrate does not provide you enough citrate to be of any use. So sodium citrate is not effective. It has to be potassium citrate. Uric acid stone in children are relatively less common, they are becoming more common in adults, and we know that they are related to the metabolic syndromes. So, but in children, the number of uric acid stone episodes are also increasingly being reported, probably because of the dietary change which has taken place, at least in the cities. So acidic urine, which is a pH of less than 5.8, is the right atmosphere. It provides the right atmosphere for the uric acid crystallization. Even children who have normal uric acid, serum uric acid levels, can also form citrate uric acid stones. So the serum levels are not to exclude that they would not form uric acid stone. So hyperoxaluria, hyperuricosuria, typically seen in myeloproliferative disorders, unless it is an inborn error of metabolism in which the xanthine oxidase system is not functioning, and as a consequence, the citrate keeps, uric acid keep high volumes of uric acid excreted in the urine. The treatment of uric acid stone is to alkalinize urine, and you can alkalinize urine using potassium citrate or soda bicarbonate, and they both are effective. So soda bicarb also provides enough. Can people turn off their audios? It's disturbing. Or use of allopurinol, and more recently the use of buxostat agent for uric acid. The citrate is followed by cystine, and cystine is even rarer disease in which there is an error of metabolism related to 4 amino acids, and cystine is one of them. The other one are ornithine, lysine, and arginine. These stones typically form in higher pH, so you need to alkalinize, in acidic pH, which is less than, so you need to alkalinize urine or use D-penicillamine and mercaptopropanyl glycine. I don't know if the other one, alpha mercaptopropanyl glycine, is available or not, but D-penicillamine is definitely available in Pakistan. The infection stones are a particularly disturbing issue both in adults and children. This is secondary to the production of urease producing bacteria, and the urease producing bacteria results in breakdown of urea into ammonia and bicarbonate. The bicarbonate changes to carbonic acid or carbonate, which in turn increases the pH, which in turn, along with magnesium, high pH, carbonate and magnesium together form the MAP stone, or magnesium ammonium phosphate stone. So the ammonium is available, magnesium is there in the urine. The pH is suitable for aggregation, crystallization, forms the magnesium ammonium phosphate and carbonate apatite stone. And these are both the forms which are seen in patients who've got infections. So this is an important thing, because unless you take care of the primary offending agent, these stones are notorious in recurrence. So they can form in a matter of weeks. So no sooner you have treated a patient with an infection stone, you have asked them to come back in 4 weeks' time, and if you have not treated their infection, these stones you can start seeing another stone. So this can be very embarrassing at times. The xanthine is another type, typically seen in one of the inborn errors of metabolism called Lesch-Nyhan syndrome, but this is extremely rare. Now, if you have a child who is suspected of having urolithiasis, history, physical examination, along with all the workup are extremely important. Because you need to consider this, that a child who has got a suspicion of stone and he comes out to having a stone is a condition which is going to be recurrent, a condition which will keep bothering the child and the family unless you take proper corrective measures. So it's important that you just don't look at the CT scan or an ultrasound or an X-ray and decide what kind of endourological treatment you want to offer to the child, but you would look at the whole history and look at the child as complete, and do all the basic physical examination. You take a good history. Dietary habits are also important. What the mother is feeding them is important. And once you have done that, few spot urinary samples, as I have talked about earlier, the calcium, creatine, and oxalate creatine ratios are important to see what is the probable cause of urolithiasis and how can they be treated on a long-term basis. So dietary and regular food habits. The imaging is, we're going to talk a little in great detail about imaging, but sonography, because of its safety, is the first line. Unfortunately, sonography has its certain down points as well, which we're going to talk about. But because of its safety profile, it often is the first investigation of choice. Stone analysis by infrared spectroscopy is important. Just by chemical analysis, you not the mineral content of the stone, and without that, it is difficult to really formulate a strategy to. And stone analysis, both in adults and children, is a step towards stone prevention. So this is most important on every episode, because this is a dynamic process. So if this child has formed a stone, from the stone of the same type 3 years later. So it's recommended that these children and even adults have. In the subsequent visit, you need to talk about dietary measures and recommend dietary things, because these children will develop certain habits and that will last the rest of their life. So it is important that these habits are corrected in order to avoid recurrence of episodes. So let's talk a little bit about imaging. It's not very different from adults, but there are a few aspects that you probably need to be careful about. Acute colic, the EU recommendation is that initial ultrasound, but if there is any doubt in making a decision about the treatment of the child, then it is important that you do a non-contrast CT. Now, a non-contrast CT is superior to IVU. We all know that. Non-contrast CT in children, particularly in younger children, should better be done with radiation protocols. So these should preferably done. Now, what should be the imaging prior to an intervention? Lithotripsy, be it ureteroscopy, or be it percutaneous surgery. It's important that you have some anatomical details, and they are more important in children than, because if adults have something, it would probably have been. It's important that you have necessary information for the treatment. Okay. Now, MRI scan is also one of the modalities. MR urography and MRU is important, but remember that stone identification on MR is more indirect rather than as in CT, which is a more direct. You can see a high density shadow, you can see the collecting system, everything. But in MR, it is more of a filling defect. So if you're doing an MR, without contrast, it would be counterproductive. So you need to do your MR with contrast, and you have to see whether the child can receive contrast. Now, plain X-ray is again important, not only to know if the stone is radio opaque, and we know that calcium oxalate, monohydrate, dihydrate, and calcium phosphate stones are the typical radio opaque stones, and they are the predominant stones. So in about 50 to 60% of cases, your stones are calcium oxalate, calcium phosphate. So if you do X-rays, you would know whether they're visible or not, meaning that they are radio opaque or lucent, and then use the X-ray for follow-up as well. The poor radio opacity is seen in magnesium ammonium phosphate stones, apatite stones, and cysteine stones, but often cysteine stones are associated with calcium oxalate as well. So it's calcium oxalate sometimes can give them radio opacity. So pure cysteine stone are relatively less frequently seen. So purely radiolucent stones are the uric acid stones, the ammonium urate stones, xanthine stones, and certain drug stones. And we know that Indiana, where the medication is one of the drugs which can form stone, and they are not even picked up on CT. So a plain X-ray gives you a lot of information about not only stone's presence otherwise, but also from the perspective of how to follow them up subsequently and what the type that you are, what type of stone are you expecting. Now, it's important in adults, but it's more important in children that you should know how much of radiation exposure is there. These are growing individuals, and they are more prone to radiation related issues, and they will be living much longer than an adult. So radiation exposure is important. Where an X-ray KUB gives about 0.5 to 1 millisieverts, an IVU, a short IVU, a three film IVU would give you about 1.5 millisieverts, but a proper IVU, which used to be done in the olden days, can give up to 3.5 millisieverts. The regular CT KUB or non-contrast CT that you do is about 4.5 millisieverts to 5 millisieverts. But if you do a low dose CT, you can see that the radiation can come down significantly. So it's a matter of how do you do your settings of pitch and other parameters. You will be able to reduce the radiation significantly. So even 1 to 2 millisievert is the exposure with a low dose CT. Whereas remember that if you want to do a contrast CT gives you about 20 times as much radiation. So it can be anything from 25 to 35 millisieverts. This is an article that we have written many years back. I think it's about 10 years back. And I actually proposed the title of this article as 70-year-old and time to retire. Subsequently, on the recommendation of the editorial board, we have to change it. But what I meant was that IVU is an investigation which is of more historical value now than of any contemporary significance. And this is something that we have shown about 10 years back. And as you can see in various graphs, the number of CT versus IVU have changed significantly. The number of CT scans done increased, and both in adults and in children. Can Taimur Qureshi turn off his audio, please?
ठीक है, जागा है, सो रहा है, एक्सरे हो गए.
Can you turn off your audio, please? Thank you. This trend was not only seen in adults, but also in children. That the number of IVUs done was decreasing from 2002 to 2007, whereas the number of CT scan done was increasing. And this trend is more like this now, with hardly any IVUs done in our center. Okay, so about management, and we know that the same options are available, which includes medical treatment, lithotripsy, endourology, with semi-rigid ureteroscopy or retrograde intrarenal surgery and percutaneous surgery. And in very few selected cases, lap or open surgery is also an option. See in which cases and why. So the medical management of pediatric urolithiasis is really focused upon. So there is not one formula or one pill which works for everything. Maybe potassium citrate would be counterproductive in patients who've got infection stones, because you really need to increase the pH in that situation. So hypercalciuria, if you have hypercalciuria, it is recommended that fluid intake should be increased, and this is something that you can cut and paste. And with all research that has gone in to look at various dietary factors